Hello everyone, welcome to HIM 216. This is the second in a series of lectures that you will have covering Chapter 6 in your textbook. In your textbook, we're on page 102, at the bottom of the page, discussing the closed surgical procedures that convert to an open surgical procedure. And what this actually means is that if a procedure starts out as closed, this means that they are not making a significant incision in the skin, the subcutaneous tissue, the fascia, the peritoneum, the muscle of the patient. They are using instrumentation through very small incisions to accomplish the procedure. The one you may be most familiar with is a cholecystectomy. Lots of laparoscopic cholecystectomies are performed, and this means that they use special equipment with cameras that allows them to visualize the inside of the abdomen. They then use equipment that also allows them to cut the different body structures and then be able to remove whatever it is they need to remove. Now, they don't always remove something. Sometimes laparoscopic procedures are done just to go in and look around and see what's going on. When that's done, the root operation is inspection. However, there are times when they plan to do a laparoscopic or a closed procedure, and for whatever reason they can't accomplish it, so they have to convert it to an open procedure. And a cholecystectomy is an example of that. Another example might be an appendectomy. They do laparoscopic appendectomies. Let's say that they get in there and they find out that the appendix has ruptured and they actually need to open the abdomen, drain it, rinse it out with antibiotics, maybe even leave it open to drain. Another example is a joint replacement. They are doing some hip replacements laparoscopically now, but it may be that they need to convert those to an open procedure if it's not best suited for that patient to have it done laparoscopically. Now, on the top of page 103, it talks about the different approaches. And it talks about a laparoscopic approach, and this is when procedures are performed within the abdomen. Then there is a thoracoscopic approach, and this is when they perform procedures in the thorax. And then there's an arthroscopic approach, and this is when a procedure is performed within a joint. And we'll look at these in much more detail when we actually get into looking at root operations and coding different procedures. But these are, to me, these are note card definitions. You need to know that laparoscopic is the abdomen. You wouldn't do an arthroscopic procedure on the abdomen. If you see arthroscopic, it's joint. If you see thoracoscopic, it's the thorax. So you need to learn what those approaches are and be able to differentiate between them. And many times we actually don't code laparoscopic. We actually code the definitive procedure. So for a cholecystectomy, we would look up resection of the gallbladder, and the approach would be laparoscopic. So these are approaches, and literally when we're coding in PCS, one of our characters is for the approach, and that's where this comes into play. There are times that a procedure may actually start off as a closed procedure and then it's converted to open. And we actually will have two codes for those procedures. We code the fact that it started off as a closed procedure. That procedure is coded as root operation inspection. And then the definitive procedure will actually code with a root operation that reflects the extent of the procedure that was done. It may be a resection, meaning they took out the entire organ, or it could be excision, meaning they took out a part of the organ. And we'll learn those root operations in a few lectures. The example that they have on page 103 is a patient came in for a laparoscopic cholecystectomy for chronic cholecystitis with lithiasis. Now, that is your principal diagnosis code, chronic cholecystitis with cholelithiasis. That's the principal diagnosis code. The principal procedure would be the laparoscopic cholecystectomy. But what happened is this patient had extensive adhesions of this gallbladder, so they had to convert it to an open cholecystectomy. So when we look at our diagnosis codes, we have a code for the chronic cholecystitis, we have a code for the cholelithiasis. This first procedure code is for the actual cholecystectomy, the removal of the gallbladder, and that second procedure code is actually the inspection of the gallbladder, and that tells us that when we look at this, we know that they attempted to do it laparoscopically, but then they had to convert it to an open procedure. And that fifth character is the approach. So when I look at that first code, I know that the 0 is open, and when I look at that second approach, that second code, I know that that fifth character of 4 is endoscopic. And you will learn this, and you'll be able to look at codes just like that and have an idea of how they're sequenced. So let's talk about planned and canceled procedures. Planned procedures are not always carried out. Sometimes a procedure will be scheduled and then the patient changes their mind and they just never show up. When that happens, there is no medical record generated. Sometimes the patients will come in for some pre-op testing. If they do, that account becomes a clinical account and we bill it as a clinical account. But let's say that they're scheduled to have a tubal ligation on an outpatient basis, and lab work was actually done through the physician's office, not through the hospital, and then on the day of the tubal ligation the patient just doesn't show. Well, what do you do as the hospital? What do you do? Basically, you have no medical record. The patient didn't show up. The account is canceled. There's nothing to bill. And so really there is no record that was generated. We just do not maintain those documents. Now sometimes a procedure is canceled, and there are different reasons that a procedure can be canceled, and you will remember that we actually looked in the integrated code book at some of the reasons that a procedure could be canceled. Hold on just a second. Here we go. And if I look at canceled procedure because of, and the category is Z53, persons encountering health services for procedures and treatment not carried out. And some of those could be a contradiction, meaning maybe the patient has a medical condition that and the surgery gets canceled because of that. Sometimes they'll leave AMA, they'll just change their mind and get up and leave and not tell anybody. Patient's decision means that the patient verbalized that they had changed their mind, and then that actually is subdivided so that you can designate if for some reason they had a religious belief. Maybe you know, sometimes there are religious groups that refuse to agree to a blood transfusion if it's needed, and there are surgeons who have said, I will not perform surgery on you if you refuse blood if you need it. And so it may be canceled because the patient says no, they won't accept blood, and the physician says, then I won't do surgery. Or it may be group pressure. Maybe a woman plans to have a tubal and her family or her spouse talk her into changing her mind. There could be some other specified reason that the patient would change her mind, or there could be a specified reason, another reason that the patient decided not to have the procedure done. At any rate, the principal diagnosis for in this instance is going to be the reason the patient was going to have the procedure performed. So in the instance of a patient that was going to have a tubal ligation, the diagnosis for that is desire sterilization, admission for sterilization. And if there's a complication that arose, then let's say that a patient comes in actually with cataracts for a phacoemulsification, and then in the pre-op area they go into atrial fib. The cataract would still be the principal diagnosis code, and then you would code that complication, which would be the atrial fib, and then you would also have a Z code that reflects why that procedure was not done. And this is all discussed on page 103. We have some examples here we can look at. In this first example, the patient came in for a hysterectomy because of uterine fibroids. Now, the principal diagnosis here is going to be uterine fibroids, or leiomyoma of the uterus. But shortly after the patient came in, she told the nurse that she was having second thoughts and she was not going to have the procedure, and so she was discharged. So our principal diagnosis code is D25.9, which is the leiomyoma. And then the Z53.29, that is the specified reason, NEC, patient's decision. There is no procedure code because no procedure was done. We can't code the hysterectomy because the patient did not have it. So in this second example, the patient came in for coronary artery bypass grafting because of coronary atherosclerosis of native arteries. The principal diagnosis here is coronary atherosclerosis of native arteries. The procedure that they planned was a CABG, coronary artery bypass grafting. But the surgeon became ill, so this procedure had to be rescheduled. So the patient was discharged. The principal diagnosis is I25.10, which is the atherosclerosis, and then Z53.8. We had a specified reason, which was that the surgeon became ill. So that's our Z53.8. In the next example, the patient was admitted for a laparoscopic cholecystectomy for cholelithiasis of the gallbladder. The patient was having an acute exacerbation of his COPD, chronic obstructive pulmonary disease. So they treated that patient with steroids and a nebulizer, and then the patient was discharged. The cholecystectomy was rescheduled. So in this instance, the fact that the patient had an acute exacerbation of COPD does not change that principal diagnosis. The principal diagnosis is still going to be the cholelithiasis, and that's the K80.20, and then the COPD, that code is the J44.1, and then Z53.09, canceled because of contraindication. So that exacerbation of COPD is an example of the contraindication. On page 104, it begins talking about a surgical procedure that was started, and for some reason it's not completed. Maybe the patient has a problem once they cut or once they administer the anesthesia. So the procedure is only coded to the extent that it was performed. Now, this is different than a procedure that was canceled. In a procedure that was canceled, the patient never went into the operating room. But once the patient goes into the operating room, then we're talking about it's a different circumstance. So in this example, the patient is coming in for a colon resection because of cancer of the descending colon. So our principal diagnosis here is cancer of the descending colon. So they made an incision through the skin, a laparotomy. That's what the incision in the skin, that incision in the abdomen is a laparotomy, and they went through the subcutaneous tissue and the fascia, and then the patient became unstable and had atrial fib. So they decided that they would terminate that procedure, and so they closed the patient up and transferred the patient to ICU. So in this instance, this procedure code basically is just the incision into the abdomen. And if we go over and we look at this particular code, we're in medical surgical, and this is the incision went through the subcutaneous tissue and the fascia. And this root operation is inspection because basically that's all that they could do, and this was the subcutaneous tissue of the fascia and the trunk. It was open, there was no device and no qualifier. So that's as far as this procedure went. And that coding will make more sense to you, I promise, when we actually go in and start looking at root operations. Bilateral procedures. This is when the same procedure is performed on paired anatomic organs or tissues. There are some bilateral codes, and it's just one code, but if there's not a bilateral code, then you have to code it twice. And I'll show you an example of that. Okay, so resection of the fallopian tubes. This is a tubal ligation. I have a code for the left tube and a code for the right tube, and you're going to say, well, why would anybody just have a tubal on one side? Well, they may have had the other tube removed for some reason in the past. And then there's the code for bilateral. These all go to the same table. This table is OUT. And then the body part, we're choosing bilateral, but you can see here grayed out. If I undo that 7, you can see that I could choose right or left, but mine was bilateral, so that's what I'll choose. Now, let's look at a patient who has bilateral knee replacements, and sometimes patients go in and have both knees replaced at the same time. There is a code for left and there is a code for right. There is not a bilateral code. So this is an example of when we would code the left and the right if they were both done at the same time. And you have some examples here that demonstrate this coding as well. Every facility must have coding policies and procedures. If you go to work in a facility as a coder, one of the first things they should do as part of your orientation process is give you the facility coding policies and procedures to read so that you know what their policies are. When we're doing coding, we're doing data collection, and all types of areas are impacted by that. Reimbursement, research, the physician profiles and credentialing, data analysis. These are all reasons that we want to be very meticulous in our coding, and they all need to be addressed in policy. Your facility policy should talk about the actual coding process, the fact that we review an entire record. It should include the types of procedures that are coded in HIM. In my facilities, we actually had a document about what we didn't code in HIM. We had a who codes for what tool, and it literally broke down CPT codes and identified what we coded, what was coded from the charge master. On the bottom of page 104, it talks about the history of ICD-10. And there are significant differences between coding procedures in ICD-9 and the procedural coding system in ICD-10. In ICD-9, we actually had 3 volumes. The index and the tabular, we have those in ICD-10, but volume 3 of ICD-9 was the index and the tabular for procedures. In ICD-10, we actually, in the procedural coding system, we have a very different format. I-9 procedures were very similar to the diagnosis codes, but in ICD-10 they are very different. In your book it has the structure for the more detail about these, which you can certainly look at. One of the important things about all codes in ICD-10 is they are all 7 characters long. Every PCS code is 7 characters. Now remember that diagnosis codes in the diagnosis tab can be anywhere from 3 to 7 alphanumeric characters, but in PCS they are all 7 alphanumeric characters in length. And one of the important differences is that in the diagnosis coding we use the letter O. In the procedural coding system we do not use the letter O. We use the number 0, and I have to catch myself all the time and remind myself not to say an O when I mean a 0, because electronically, if the system is looking for a 0, it will not recognize an O. And you know very well that an O and a 0 look very different when you type them. Type them in Word, type them in Excel, and look at them. You can tell the difference. An O is round, a 0 is more oval. You're going to have to be very careful when you're writing your codes that you differentiate between an O and a 0. They're completely different in the electronic world. In ICD-10, they had goals for completeness. They wanted expandability, and it just basically almost has unlimited expandability. It's multi-axle. It uses standard terminology. That means that the characters within a section have the same meaning. So every character in medical surgical has the same meaning. There's a body system, the root operation, a body part, approach, device. Let me put this over here so you can see it. And I want to show you something here while I'm thinking about it. Do you see this body part? There's a question mark there. If I click on that question mark, it gives me specific information about body part. And it also tells me, for instance, if I look at fallopian tube, that includes the oviduct, the salpinx, and the uterine tube. So that's very important. Sometimes the particular body part you're looking for isn't listed separately, but if you click on body part, then you can see what's included. When I click on approach, I can see a more detailed definition of what the different approaches are that are listed here. And device and qualifier don't have a question mark beside them because there are no options. On page 105 in your book, it basically tells you that we use the numbers 0 through 9 and the letters A through Z, but we do not use the letter I or the letter 0 in the procedural coding system. And it's easy to get things confused. When you're just learning, you can confuse an O with a 0. You can confuse a Z with a 2. And actually, when I write my characters, I actually take the Z Okay, I'm not sure that... I think I had a pause in this recording and didn't realize it. I'm going to go back one slide. The differences between I9 and I10 are clearly shown on page 105 in your book. I want to point out to you that of the characters that are used in PCS, we use all of the numbers 0 through 9. We use all of the letters except the letter I and the letter O. If you're writing the number 2, it can be confused with a Z. So when I'm writing a Z, I put a line through my Z. You can also confuse the letter S with the number 5. So I write my 5s very carefully. And then we are progressing to GEMS, General Equivalency Mappings. And literally, these are tables that map ICD-9 codes to ICD-10 PCS codes, and then PCS codes to I9 codes. And I want to demo that for you at the CMS webpage. So I'm going to take us to the CMS webpage, and I am www.cms.gov. I'm clicking on Medicare, and I'm going down to coding, and I'm going to click on ICD-10. And when I come over here, you can see that the GEMS are listed. There are GEMS for ICD-9 CM codes to ICD-10 CM codes, and then also for the GEMS for PCS. So I'm going to click on the, well, let me see here. We do have 2016 PCS and GEMS. And when I go over here, I can see the general equivalency mappings. And there's I9 to PCS and PCS to I9. So that's what these are. I'm going to open the I9 to PCS. This first column is actually an I9 code. We would write this with a 0, with a dot after the first 2 characters. In ICD-9, the codes are 2, they're all numeric. So there are 2 numbers and then a period and then either 1 or 2 more codes. So when I look at this table, I know that this I9 code is 00.01. The equivalent PCS code is 6A750Z4, and don't pay attention to that 1000. But I can go down through this table. For instance, this code is 78.57, and you can see, look at all these 78.57 codes. There's a bunch of them. And the reason there are is because there are so many possible ICD-10 codes for that one ICD-9 code. One of the reasons for transitioning from I-9 to I-10 was that we were out of codes in I-9 and we needed much greater specificity. Well, here is a perfect example of that. We have, and you'll see these codes, these I-9 codes repeated over and over, and it is because there are so many different codes in PCS because of the greater specificity. So if I choose this, these are the PCS codes, and these are the I-9 codes that they map to. So, for instance, when I look at these first two codes, they both map to 02.31. When I look at the next two codes, they both map to 02.32. And as we go down, we'll find the same. Consistently, we'll see the ICD-10 codes that all map to the same ICD-9 code because there's so much more specificity in ICD-10. But that is how you get to the GEMS, is through the Medicare website, and literally we go into I-10, and then from the left-hand panel we choose the appropriate the PCS and GEMS table. And you can play around with that. Now that is going to conclude this lecture, this second lecture for Chapter 6. Your question for this lecture is to go to page 106 and answer question 1 and question 3, and actually they're asking you to look at the GEMS table and to identify the appropriate code, and they're referring you back to the tables on page 105. Let's see, 4576. No, they're not. They're telling you to go to the CMS GEMS table. And we just demoed that. If you have any questions about that, you can let me know if you have any questions with that. And again, I closed out that web page. But again, you will be going to cms.gov, choosing Medicare, choosing ICD-10, and then choosing the 2016 PCS GEMS table. And that will conclude this lecture.